Thank you very much. My name is Keith McBain. I'm the Director of Business Development and Contracts in our residential and assisted living portfolio. I'm from the Fraser Health region, which is outside Vancouver. I'll show you a little bit about it. I'm responsible for the assisted living program at Fraser Health, as well as our contracted residential care partners. So today I'm going to give you a little bit of a brief overview of Fraser Health and what it is. I'm also going to talk a little bit about something we call a care delivery model that we've recently implemented this year. And I think after listening to what I have to say about the care model, you'll understand the driving force between what led actually to a collaboration between ourselves and Strata Health with regards to the creation of Strata Health IQ. So all the dots will eventually kind of get together. So in terms of Fraser Health, we're a large health authority. We're Canada's most populous health authority. If anybody here is from Alberta Health Services, you don't count because you're not really a health authority anymore. You're a ministry dressed up as a services. But anyhow, we have 1.6 million people in our health region. It's growing dramatically. We're one of the fastest growing areas of Canada. We have 12 acute care hospitals. We currently have 7,800 residential care beds at 78 different sites. Of those 7,800 beds, approximately 6,000 of those beds are with our contracted partners, and the remaining 1,800 or so are actually owned and operated by Fraser Health. We have a tremendous amount of growth in our residential care program expected. I'm not going to spend a lot of time today talking about our issues and challenges, but suffice it to say we have a tremendous amount of growth that we're expecting in the residential care world, and it's not even the baby boom generation. That's another crisis away. To give you some example, I just looked at some of our population stats the other day, and by 2014, Fraser Health needs to add 1,000 new residential care beds to maintain the ratio that we have today. And we're struggling with the ratio that we have today. So it's significant. The numbers are huge. We have half of our beds in residential care do not meet complex care requirements. They need to be rebuilt. We've estimated that of those beds, about 4,000 need to be rebuilt at a capital cost of $1 billion. That's just for Fraser. So obviously that means an increase of operating dollars for us in order to service somebody else's new debt. So lots of challenges. The assisted living program is a relatively new program for Fraser Health and actually the province of British Columbia. We brought it in about 7 years ago. For those that are aware of BC's old healthcare system, it's kind of the intermediate care level. So these are people that still are able to make decisions on their own behalf. They need assistance with ADLs, med management, but they still have sufficient cognition to have the right to live at risk, as we all do. And that's been a tremendous success of our program. We've done some satisfaction surveys that show that 95% of our people who receive those services are satisfied with those services. So it's a bright light on our part. We have 23,000 employees, and we also have 2,300 physicians. And that seems like a lot of resources, but when the health authorities came together in British Columbia in 2001 or so, Fraser Health came together as an amalgamation of other health authorities. And we weren't, frankly, as well resourced as our cousins in Vancouver. And so, frankly, we've been playing catch-up ever since. So what that really means, and what the message I'm trying to get across, is that we have to be more efficient with what we've got, because we don't have potholes of money in the ministry to say, here's more money, go and build some more, here, hire some more staff. We frankly don't have those resources. So it's really forcing us to be as efficient as we absolutely possibly can with what we've got. So this is just a map of, if you're not familiar with the Lower Mainland of British Columbia, so Fraser Health essentially is responsible for the suburbs of Vancouver. So anything from the Vancouver area, you see on the far left-hand side, anything to the right in the dark names of those communities, that's the Fraser Health area. To the south is the American border, to the north are mountains, and to the west is lots of water and islands, and so we're pretty landlocked. The growth is unbelievable. City of Surrey will overtake the city of Vancouver proper in terms of the largest city in British Columbia. Surrey will become Canada's third largest city in the coming years. It's not that far off. Why? Because most of the undeveloped land is in that part of the world. And if you could call housing in the Lower Mainland affordable, Surrey is more affordable than other aspects of the Lower Mainland, hence the huge amount of growth that we're seeing. So in terms of why did we eventually partner up with Strata Health? And so our driving force was something we're calling the care delivery model and funding methodology. So our cousins at Vancouver Island started it first. They did it a couple of years ago. And really what it meant is that we wanted to standardize our expectations with regards to staffing levels and to care levels, and also to funding levels. And so we wanted to essentially kind of equalize the playing field. When we came together as a health region, a lot of our providers were funded by different methodologies. There was a lot of disparities. Some people were refusing people because they couldn't accept complex care clients because they didn't feel the funding was sufficient. So what this care model did for us actually is kind of equalize the playing field in a lot of ways. So what was driving it for us? Certainly increasing complex and frail nature in residential care. Certainly the population looks so significantly different than it did 5 or 10 years ago. They're older, they have far more comorbidities. The challenge we've got is our physical plant where those people are staying doesn't meet those needs as well. So it's a real struggle. As I mentioned, there's a lack of standardization to the approach to care delivery hours and funding. So what we want to do is set aside an expectation of how many direct care hours you would receive, how much funding you would receive, and what your expected outcomes were from that. The other thing that we were reacting to was healthcare shortages. Since the recession bit in, probably is not as big of an issue as it used to be, but certainly prior to 2008, it was extremely difficult to recruit RNs, LPNs, OTPTs, really, really challenging. So what we wanted to do is implement a model that made some sense, and we actually would utilize those resources properly. All right, so in other words, some sites that had too many RNs would actually start to shed those RNs and use the funds to hire other types of multidisciplinary staff. That was the concept. So really our goal was improving care to our most vulnerable population. So how are we going to meet our goal across Fraser Health in our care model? So we set a standard of hours of care across Fraser Health, and we include our owned and operated as well as our contracted partners. So for many years we said we were accused of favoring our own owned and operated sites and not properly funding or having expectations for our contracted partners. And so one of the things we wanted to do was standardize that approach. And so if the care model was good enough for our contracted partners, it was good enough for our owned and operated sites as well, and we did that. We wanted to ensure that there was a multidisciplinary team approach in place. And so some of our sites had employed a 100% RN model, and others a little bit of a mix, some LPNs, but a lot of RNs. Some didn't employ sufficient numbers of allied therapies, and so not enough OTPT. So what the model has done for us actually is spread those resources around, so there's a bit prescriptive on our part where we're saying, you know what, we want you to provide a minimum of 24/7 RNs, we expect so many hours of allied professionals, we expect so many hours of non-professionals, and so it was very prescriptive in that approach. We also had increased accountability through ongoing monitoring. So there's financial monitors, and so each quarter our contractor providers have to report their financial numbers to us and identify how they're doing against the care model. And then what we're going to talk about today is some of the other performance metrics that, as a result of our partnership with Strata Health, we're actually can actually follow. And also the key part is transparency to the public. And to our providers. Again, a lot of distrust of our partners in terms of how they were funded in the past, and wanted to make sure that how they were funded was fair. And we think that the care model has actually done that because we've been very open in terms of our expectations and how we actually derived our funding. In British Columbia, there's been a significant imposition of the Ombudsman with regards to her expectations of how seniors should be treated in the province, and so we are seeing increasing amounts of questions and I guess justification in terms of how seniors are being cared for in the province. So lots of pressure that way. So in terms of the care model, we really needed a tool to accurately measure our performance and standards, goals and standards. And so we have been using Strata Health Pathways since 2007. It was a rich amount of data that had been collected in there, but other than our community access team, acute access teams, none of us beyond that area actually had easy access into the data that was being collected. I'm told that we have approximately 2,000 matches per year in Strata Health Pathways, and I think Helen spent some time yesterday talking a little bit about the Fraser Health experience with Pathways. We also have our contracted sites and Fraser Health owned and operated sites reporting their data directly through Pathways. We actually will collect the raw data and actually upload it into Pathways, and then we use that in terms of some performance measurements, which you'll see today. So in terms of measures, what measures are important to us, especially in the first year of the care delivery model? We wanted, in terms of Pathways, we wanted to really take a look at declines and reasons for declines. So We felt prior to the care delivery model there was a culture of high declines, and probably maybe were feeling that they didn't have sufficient staffing or dollars to provide the care, and so when the match came up in pathways, they would decline it. So we're making sure, we want to make sure, as we set a benchmark, that the declines that are occurring are not being done for cherry picking reasons, because frankly a lot of people would rather have lighter folks in their care facilities rather than a whole board of really heavy people. So that's important to us. Vacancy turnaround times is also really important. Our system is so unbelievably tight that we need to have a vacant bed backfilled as quickly as possible. We had set aside a target of our owned and operated sites of 72 hours from the time in which a bed was vacated. By the time it had to be filled with somebody else, it was 72 hours. That was the target we set for ourselves. Our contractor partners, some were close to it, some are nowhere near doing that. And so again, we needed a tool to identify quickly from people at my level in the organization in terms of who's an outlier, and give a chance for my team to actually investigate why outliers were occurring. The other thing that was important to us was vacancy volumes and occupancy rates. So in our contracts, we have an expectation that they must maintain an occupancy rate of 98.5% at any given time. We'll give some relaxations if there's a flu outbreak and they have to shut intake down, or if they've got a flood or something else has happened beyond their control, then of course we'll make adjustments for that. But if they don't meet the 98.5%, we're going to be clawing money back from them in order to make sure they meet that 98.5%. So the other thing we want to take a look at, other than those kinds of measures, are clinical indicators. And we take a look at some of the clinical indicators that we're collecting from RAI and how we're going to ensure that some of our performance expectations are actually met. So one of the areas is falls. So falls is quite topical these days. We're not going to be able to benchmark in terms of how many falls per thousand we will think is acceptable. I think our first stage in falls will be to simply collect the information, ask them to collect, which for the most part are non-witness falls, are by far the largest majority of falls. Our hope would be, as we collect data within the falls area, that we actually can develop some clinical interventions to bring those falls rates down. We did some really neat stuff with our assisted living program last year. We actually did a pilot, we watched falls. We then implemented some interventions. We saw the fall rates drop, and more importantly, we saw actually the fractures due to falls start to drop as well. So we know it can be done. We felt we need a starting point with our residential folks, and that's what this is going to be. Transfers from res care to emergency, we are going to set a benchmark for that. I'm not quite sure what that benchmark is going to be in terms of an acceptable level. Suffice it to say, in Fraser, our expectation is that people should be remaining in residential care for as long as possible. And if they're palliative or close to palliative, then that's where they should remain in their days. I don't think it is a surprise to anybody in this room that sometimes seniors don't do well in acute care sites. They probably do worse in an acute care site than they do in a residential care setting. It makes far more sense to bring in the services, the proper services, in res care, rather than transferring somebody to the ED. So we'll be sending a benchmark on that. Medication errors, we're going to benchmark. That's a really simple one. The tolerance level is 0, right? So we want those reported. It's not going to be any sort of a financial penalty or a hammer coming down. It'll be more about what can we learn from your medication errors, what clinical interventions can we do to make sure those medication errors are not occurring in the future. Facility-acquired pressure ulcers. Again, we don't have a benchmark for that yet, but again, that's an issue that needs to be resolved, and frankly, it will prevent some transfers into the acute site.
Question?
Yeah.
Is this based off of Y2 data that's uploaded back through pathways?
Yes.
Okay, I misunderstood when you talked about
Yes.
interface. I was thinking RIHC data going.
No, this is RAI 2.0,
Gotcha.
right? So the residential RAI tool that's actually being uploaded from the sites, because they're using, they can use they can use Gold Care, which is what we use, and there's some other providers as well. But essentially, we take the data, upload it at the pathways, and then we're going to bring it into our dashboard, which you'll see in a minute.